I'm Dr. Stuart Menakar from the Palo Alto Medical Foundation, Los Gatos Clinic. Welcome to Health Connections on KCAT Television, Los Gatos, Monte Sereno. On tonight's episode, my guest is Dr. Alex Kim from the Department of Reproductive Endocrinology and Fertility. Welcome, Alex.
Thank you.
It's great to have you.
Thank you for having me.
So, Alex, before we talk more about the details of your work and how you help our patients, please tell us a little bit about yourself.
I'm a reproductive endocrinologist and infertility specialist, and I've been in practice for a little over 20 years now. Came out here to the Bay Area about 21 years when I started practice, and been enjoying every moment of it.
We're very happy to have you part of the PAMF team. Tell me, Alex, where'd you grow up? Where'd you go to school?
So I kind of grew up a lot of different places. Went to school in, believe it or not, in Nashville, Tennessee, in Southern California, and LA. Did my medical school in Nashville at Vanderbilt, and did my subspecialty training at Yale New Haven in Connecticut, and moved out here.
Most of our viewers probably don't know much about what it means to be a reproductive endocrinologist, or what kind of training after medical school you would have to qualify you to do that job. Would you fill us in a little bit, please?
Usually to become an infertility specialist, we have to do 4 years of training in general OBGYN. So it's a subspecialty of OBGYN, which is 3 years. So we complete our OBGYN training, and then we do infertility training for 3 years thereafter.
Well, I know how much training I've had as a physician, and you've had even more as a subspecialist. So 4 years of medical school after college. So 4 years of college, 4 years of medical school, 4 years of OBGYN residency,
yes,
and 3 more years of reproductive endocrinology and fertility.
That's correct.
That's a lot of years. 15 years after high school.
Yeah, it seems like that. It gets sometimes it takes a long time, but when you look back at it, you don't think it's
it went
that long.
quickly.
Yes.
Well, so Alex, with that kind of commitment, why do you want to be a fertility specialist?
When I went to OBGYN initially, I was really fascinated by the fact that we could practice medicine with the endocrinology aspect of things, and as well as do surgical procedures. And what was really unique about fertility is the IVF component, and that was just something that no other specialty really had, and that was very fascinating to me. That was back in the time when I was going through training, when it was very new. It was maybe 5-6 years after the first IVF baby was born, and I just was captivated by that, and I found that really fascinating. So kind of was able to meld medicine with surgery with just a very unique aspect of medicine.
I remember actually, so IVF meaning in vitro fertilization, or what a lot of people call test tube babies. Very first one was Louise Brown, who's now
over 30 years old.
Pretty amazing how much things have changed since you and I were in training a long time ago. So it's a fascinating field. Fortunately, most couples never need to see a fertility specialist. Who does need to see a specialist? What percentage of people might end up in troubles with fertility?
After a year of trying, approximately 85% of couples will conceive and get pregnant, and 15% won't. So usually we define infertility as a year of trying without being able to get pregnant. And so about 15% of people will fall into that category.
In my family practice, I see a lot of couples, some of them quite young, who are worried that they're going to have fertility issues. And they've been trying to get pregnant for 2 months or 3 months, and they're still not pregnant. So what would you recommend to me as a primary care provider that I tell my patients, or that you would tell them if they ended up in your office, about what they can do to be very likely to get pregnant without ever getting to that 1 year mark?
So I think what's really important is to be able to try to time when ovulation is happening. So having intercourse and being able to accurately time and figure out. And there are various ways of doing this. There's ways where you can use ovulation predictor kits, which is very common, and these are kits that can be purchased at any pharmacy and used to try to time when ovulation is happening. There are other ways. Nowadays, people use apps, and there are lots of phone apps that I have patients coming in and saying, yes, here's my latest app, and I'm able to track exactly when my period started, when ovulation's happening, and so that helps a lot too in terms of timing. So I think that's one way to start, and then you kind of determine when ovulation's happening is to have intercourse in appropriate timing and fashion there. Some people, by doing this, can figure out pretty quickly if they're not ovulating very regularly, or if their cycles are very irregular, then you don't need to spend much time, a year or even that long, to find out if there's a problem. So definitely In those situations, we would recommend that you come in sooner to see a specialist such as myself or your general OBGYN to start doing an evaluation of some sort.
Well, Alex, a lot of our patients who are trying to get pregnant worry about whether or not they'll be pregnant. When I, as a family doctor, know that maybe they should be worrying a little bit more about their own choices about lifestyle as ways to help them get pregnant or make sure their pregnant goes well. So can you tell our viewers a little bit about what kinds of things women, couples should and shouldn't do during the time they're trying to get pregnant?
Yeah, one of the common questions I get, especially from the men, is do I have to give up my biking or my hot tub use? And one of the things that I think from a lifestyle standpoint for the men would be to avoid frequent hot tub use because we do know that can potentially affect sperm counts. In Northern California, certainly biking is very popular, and that's a common question we get asked. And I think, for people who do a lot of bike rides that are extremely long, it potentially could have some impact. So if there is a problem with fertility and we evaluate the semen analysis and there seems to be an issue with that, that's one thing that we probably would recommend to kind of reduce. Other things that can affect fertility, both in men and women, would be smoking. Drug use obviously is not good for either sperm or eggs. Generally, we usually recommend healthy lifestyles for both. That is eating well, balanced diet, maintaining weight, especially too. It's a common problem we encounter is that, especially on the women's side, that if there's excess weight, that can affect fertility. It can affect ovulation, it increases miscarriage rates, makes it harder to get pregnant, and also response to treatments. If we need to do treatments, is more difficult. A common question I get asked also is about nutritional supplements and what role does that play in fertility. And nutritional supplements, I think, are, especially taking prenatal vitamins, is certainly recommended. A multivitamin on the men's side is reasonable as well. Other nutritional supplements are generally okay and pretty safe to take. We just have to be careful about what types they are and making sure that they don't interfere with perhaps whatever treatments that we may want to pursue. So I think it's important before taking any nutritional supplements is to ask your OBGYN or fertility expert to see if those are okay to be taken. But for the most part, vitamins are usually pretty safe.
How about the myth or the thought, the idea that exercise is not good for women who are trying to get pregnant or who are in pregnancy? Mm-hmm.
Generally, exercise is still okay to do. In fact, I usually recommend at least some degree of exercise to pursue. I think too much exercise can be detrimental. So if it's causing irregularities of the menstrual cycle, then we know that exercise is too much, that it's disrupting the normal menstrual function, so that's not good. But I think general, light exercise daily or every other day is certainly reasonable, and I think it's fine to do.
You talked about supplements and those sorts of things, but I know there are other things that couples might do to try to help lower stress or help in other ways with getting pregnancy. Because, if you're trying to get pregnant, especially if you're having issues with fertility, that sounds pretty stressful to me. How can we help, or what should people do on their own?
Yeah, I think stress is a very big component because these days, especially working here in the Valley, can be very stressful. And just trying to get pregnant in and of itself can cause a lot of stress as well. Stress reduction is highly encouraged to be able to do things that can reduce stress. And for different people, that might be different things. For example, some people exercise helps them reduce stress. Some people it could be meditation. Some people it could be acupuncture. We even have mind-body programs, yoga, counselors who can help with stress reduction. So I think it's a very big component because we do know that stress can have physical effects like disrupting normal menstrual function that can affect fertility, but also it is probably one of the biggest reasons people don't pursue or people drop out of treatment, fertility treatment that's really needed to help pregnancy occur. So it is a very big component to understand that if stress is playing a role, to seek some sort of remedy or treatment to try to reduce that.
So stress reduction and mind-body stress management, the folks who teach that to patients are part of our team here at the Palo Alto Medical Foundation as well, in your office.
That's right. We do have a mind-body program. We have different length sessions for that, for people who find the need that would be a benefit to them. And I think that can be a very important component because it is recognized that even going through treatments can be a very stressful process. So I think it can be a very helpful program.
Well, Alex, you mentioned things like prenatal vitamins and multivitamins. But many of my patients take herbal remedies, natural remedies, Ayurvedic treatments to help with fertility. What do you think of that?
Herbal remedies, we have to be cautious because sometimes these herbal remedies may contain hormonally active compounds that could disrupt normal menstrual function, may interfere with the treatments that we're trying to do, the hormonal treatments. And so usually we generally counsel to avoid the herbal remedies while we're going through fertility treatments. So if herbal remedies are recommended, definitely mention that to your OBGYN or fertility expert, and that way we can make recommendations related to whether that might be beneficial or not.
So in my family practice, I see a lot of couples trying to get pregnant, and usually for those women who are 35 years or older, we don't have them wait a full year of trying to get pregnant because we know their chance of fertility troubles is a little bit higher. So maybe after 6 months or so, I would ask them to see their OBGYN or to see a fertility specialist. But in young couples, really waiting pretty much a year of trying because their risk of fertility problems is pretty low. Does that sound about right?
Absolutely, yes. So what's really important to age is really the key determinant of this. If we look at statistically, the average chance of getting pregnant per month, it's about 20% per month. That's what we call the fecundity, which we usually define as chance of having a live birth in any given month. And that level stays roughly about similar up to about the low 30s. And drops off slightly as you get up to age 35, but probably not significant enough to worry about it. So that's why we say up to about age 35, waiting about a year of trying is certainly reasonable before getting too worried or concerned. But once we get to 35 and above, that's when we start seeing fertility rates drop off pretty considerably. So the average chance of getting pregnant per month just trying on your own naturally is about 17% at age 35, but by the time you get to 40, it drops down to about 9%. So you can see the drop-off is far more dramatic. And that's why 35 and older, we usually recommend after 6 months of trying, at least starting to do some sort of workup or testing to see if there may be a problem that we can act on sooner so that time doesn't go by and the fertility rates decline as we're waiting.
So we've been talking about the age of the woman. Does the age of the woman's partner, the husband or partner, make a difference?
It does. There's a little bit more leeway when it comes to men, but clearly there's data to indicate that even in men, as age increases, there's drop-offs in sperm quality, sperm count, and as a result, fertility rates can suffer as a result of that. But men have a little more leeway. They can be a little more older before we start really seeing more significant effects or impacts on fertility as compared to women.
You know, we've talked about women, couples where the woman is 35 or older, coming in or getting some evaluation at 6 months, younger folks at about a year. Which doctor should they see when they're first beginning to be concerned about their fertility?
I think seeing their general OBGYN is really a good start. And they can usually vet and determine if there's any major problem that could be going on with their fertility, or if there's something that they could perhaps take care of, maybe some basic testing, maybe some even initial low-level treatments that they can do themselves. So I think a good start would be with the OBGYN.
What should a couple expect from their primary OBGYN in terms of testing, evaluation, or treatment that they would have before coming to see you as a fertility specialist?
Mm-hmm. Generally, the OBGYNs will start by getting a medical history, GYN history, to see if there are any problems such as endometriosis, fibroids, irregular menstrual cycles. They'll also oftentimes order some blood tests initially to check for ovarian reserve and other hormonal problems that might exist. And they may even order, for example, a test called a hysterosalpingogram or an HSG, which is a test to find out if the fallopian tubes are open or blocked. Oftentimes they'll also order a semen analysis for the men.
Alex, what do you mean when you say ovarian reserve? What is that?
Mm-hmm. Usually we define ovarian reserve as the reproductive potential with respect to the follicle count and the quality of the eggs.
So the way I understand it is baby girls are born with all the eggs they'll ever produce their whole life. And so that's part of why their fertility issues as the eggs age a little bit. Mm-hmm. Whereas on the guy's side, they produce new sperm perhaps all the way up into their old age.
That's right. Yes, that's an important point to keep in mind is that interesting fact is that the most number of eggs that women have is actually before they're born. Usually at about a 20-week fetus is a peak number of eggs, which is about 5 to 6 million eggs. And then when birth occurs, the number of eggs is down to about 1 to 2 million. And then by the time puberty comes along, it's down to a few 100,000. So there's a constant loss of eggs. And then those eggs from puberty on to menopause is what's being used during that time frame. So no new eggs are being generated. So as age increases, there's just going to be a gradual decline in the number of eggs and as well as the quality.
Well, let's say that a couple has seen the OBGYN, they've been trying to get pregnant for a year or more, things haven't gone the way they'd like. They've had some hormone testing, maybe the test, the hysterosalpingogram, to make sure that the tubes between the ovary and the uterus are open, so we know the eggs can get into the uterus. They've had the semen tested. Things just aren't working right, and they show up in your office. Mm-hmm. What do you say to them? What should they expect when they come to see you first?
Well, initially, when someone has to see specialists such as myself, we definitely go through their full history and see if there's anything within their history that could point out any problems that would point to as what the problem might be. Sometimes they'll come from their OBGYN's office already knowing what the issue might be. For example, it could be a severe male factor problem, or it could be blocked tubes, or very irregular cycles. So we'll start with that, and then if there are any other further tests that we need to order, then we'll go ahead and order those tests, whether it be blood tests or other diagnostic imaging tests. And then based on those tests, once we get those results back, then we make our recommendations as to what types of treatments would be recommended. Mm-hmm.
Oh, well, I don't want to point fingers, but when we think about causes of infertility, mm-hmm. Is it mostly because of the guys? Is it mostly something with the women? Is it a combination? What do you see?
Mm-hmm. As far as causes of infertility are concerned, about 30% are due to male only, 30% to female only, and about 30% are due to a combination of both. And there's a category of unexplained infertility. About 10% of people fall into that category.
Mm-hmm. So you've now done evaluation with hormone tests, blood tests, imaging, ultrasounds or hysterosalpingogram, those things. Tell us a little bit about treatments for different kinds of infertility, please.
Mm-hmm. Yeah, the various treatment categories, there are 3 basic treatment categories that most people will undergo. The first and the easiest treatment category is the use of a medication called Clomid or letrozole. So we call these the oral ovulation stimulating medications. And they're very common. Most people have heard of them and know friends who have taken them. And they're usually used to stimulate follicular production. So it's very commonly used in those people who don't ovulate regularly. And so if you don't ovulate regularly, we want to give you medications to try to stimulate follicular production. And then depending on the sperm analysis and depending on if a patient wants to do this, we can also add in intrauterine inseminations, which is where we take the sperm and inject it directly into the uterine cavity, and timing it, of course, according to when ovulation is happening. A second category of treatment would be the use of what we call gonadotropins. And these are actually FSH hormones that are actually injected daily and are also used to stimulate the ovaries, such as the Clomid, except it's a stronger drug. So these drugs can produce more follicles if needed, and they're usually tend to be more consistent in terms of stimulating the ovaries to produce eggs. Mm-hmm. And again, we can combine it with inseminations.
So Alex, let me interrupt for just a moment. Mm-hmm. Sorry, but I just want to make sure our viewers understand. So the ovary is the organ inside the woman where the eggs are produced. And eggs are there from the beginning, as we said. Mm-hmm. Now, as an egg gets ready to be ovulated or to come out of the ovary and go down the tube into the uterus, it's in what's called the follicle, and that's really, it's like the nursery, right? It nourishes the egg, gets it all ready to make a baby. And then ovulation is when it comes out, goes down the tubes into the uterus. And so you're talking about medicines that would stimulate more follicles to get their eggs ready to ovulate. Mm-hmm. And maybe even lead to ovulation of more than one egg? Could that happen?
That could happen too, yes. And that's one of the common complications that occurs with fertility treatments, is the risks of multiple pregnancies. And it's directly a result of typically stimulating more follicles to be produced and more eggs to be released in any given cycle. And with these medications, it's very difficult to control that. If we could, that would be great. But there's always variability in the way a person responds to the medications. And of course, I have commonly patients that come in and say, can I have twins? And can I have a multiple? And I think that's, they say it's not a complication, it's a benefit. But generally we look at that as more of a complication, and the OBGYNs would be grateful if they had one at a time.
So a complication only because the risk of pregnancy and delivery, if you have more than one baby in there, goes up.
That's
the risk
correct.
for troubles. But the way I understand it, even with use of follicle stimulants or gonadotropins, most women who, when they get pregnant with fertility treatment, still just have one baby.
That's correct. The vast majority of people do. So for example, the medication I mentioned with the oral medications, typically the multiple pregnancy rate is less than 10%. So when people get pregnant, less than 10% chance of having a multiple, and most of those would be twins. It's pretty rare to get triplets or higher. On the other hand, with the hormone injections, the rates of multiples go up and the chance of having a higher than twin pregnancy does increase, but still overall less than 5% chance of having a high multiple.
Alex, what's the rate of twins or more in the general population without fertility treatment?
Without fertility treatment, generally about 1%, 1 to 2% maybe.
So quite a bit higher, but still not, dramatic.
Correct, that's correct.
Okay, so you've talked about the first two kinds of treatment. What's the third?
Then the third treatment would be in vitro fertilization, or IVF. And that's a treatment where patients would take the fertility drugs and stimulate the ovaries to produce many, many follicles. So in this situation, we do want to get a lot of eggs to be produced. And then what we do, the major difference is that we actually remove the eggs directly from the ovary, and then we fertilize those eggs in the laboratory. So we let the embryos, the fertilized eggs and embryos develop in the laboratory, as opposed to most situations where it just develops inside the body, in the uterus. And then after a certain stage of development, then we place these embryos directly back inside the uterine cavity.
What's the success rate of IVF treatments?
Well, the success rate of IVF really highly depends on the age of the patient. They can range from as low as less than 5%, but as high as 35 to 40% for most people. So in general, most people who will be going through IVF will probably have success rates in the range of the mid-30s for most situations. There can be situations, mainly because of older age, or if the ovarian reserve is really low, then the success rates will be lower with IVF.
Can a couple go through IVF treatment more than one time?
Yes. So generally for any fertility treatment, the usual recommendation is anywhere from 3 to 6 cycles. Now part of that is where we will give guidance to you to determine what would be the appropriate number of cycles to try. And what's important, what I usually explain to patients every time when they come in, is that each time you do a fertility treatment, there's a certain chance of success depending on the type of treatment and depending on your diagnosis. But the more times you do try, the cumulative chance of being pregnant increases. So each time you try, the success rate is about the same. But the more times you try, it's just like rolling the dice. More rolls of the dice you get, the better the chance eventually of something happening.
Let's hope they don't come up snake eyes.
That's right.
So far we've talked really about women who just need a little help with ovarian stimulation, or men together who may need IVF or something like that. And by the way, I think sometimes men take Clomid to help stimulate sperm production. Is that right?
That's right. So sometimes it's used because some men have hormonal problems that will benefit from the use of Clomid to stimulate the hormones to increase the sperm production. And sometimes Clomid is used in men empirically, which means that maybe there might not be an exact cause as to why the sperm count might be low or the motility might be low, but it might be worth a try to try some medication to see if perhaps that might help with the sperm count.
Well, when we're talking about men, what about those cases, and unfortunately there are some, where you're just not going to be able to stimulate sperm production. We do a semen analysis and a man has no sperm. How do you help that couple?
If we do a semen analysis and we find that there's no sperm present, then really the options we present are the use of donor sperm. And that's not a very common scenario. Most of the times we may do a semen analysis and there's no sperm, but there is actually sperm production. So it may not come out and be present in the semen analysis, but the testicles are still producing some sperm, and we can the urologist usually can verify that by doing a biopsy, for example. And if that's the case, then we can use that type of sperm in an IVF situation. But if there's absolutely no sperm production by the testes, then donor sperm would be the option.
So if a man is producing sperm, but they don't find their way out during intercourse, you could have a different specialist, a urologist, take a piece of the testicle that's making sperm, take the sperm out of that, and then combine it with the woman's egg in the petri dish, the test tube, and insert embryos in the mom, just like any other IVF.
That's correct.
That sounds complicated.
Yeah. So the urologist would be the person who would do the extraction part, and then they would hand the specimen to us, and we would look for the sperm under the microscope and be able to use that sperm, hopefully, to fertilize the eggs. Now, there are other situations where there may not be any sperm in the semen analysis. There could be obstructions, for example. Some people are born without a vas deferens, which is one of the tubes that connects allows the sperm to come out. And if they have an absence of that, then it won't show up in the semen analysis, but there's usually plenty of sperm that's being produced. So that's just a matter of extracting the sperm to use it for an IVF process. And then, of course, the most obvious, which most people know about, is if they've had vasectomies in the past, then, of course, there won't be any sperm coming out, but then that can be corrected surgically.
Well, I do vasectomies. Sorry, we're on the wrong side of that object. But usually, hopefully, the people who come to me for their vasectomies are done having kids. I think I've only had one patient who got his vasectomy reversed. Yes, we hope there's no sperm coming out in those men. Just briefly, before we talk more about other treatments, I'd like to step back for a moment and say, we've talked about, removing eggs from the woman, fertilizing the eggs, collecting sperm, all these things. Where does all that happen? I mean, do you guys, send women off to, Washington, D.C. to get it done? Or do we, drop stuff in the mail and you get fertilized embryos back? What happens?
Well, so usually all this takes place in an IVF lab. And so right adjacent to our office, we have our own IVF lab. And that's where all the procedures take place, where we do all the embryology work, taking care of the eggs, the sperm, growing the embryos, and any other procedures that are related to the IVF process.
For our viewers, if they've seen any of our other Health Connections programs, you've heard me say over and over and over that we work here at the Palo Alto Medical Foundation as a team. Dr. Kim has an office where there are more other people working in the office than physicians. A big team of folks who are assistants, who help with the routine examination of folks, but an embryologist, someone who nurtures those embryos while they're growing in the lab, just a few feet from Dr. Kim's office. Technicians who help with the harvesting of eggs with Dr. Kim. They're like surgical technicians. Other folks would help with the implantation of embryos, people who do the evaluation of the eggs, of the sperm, all of those things as a big team right here at the Palo Alto Medical Foundation.
Yes, that's absolutely right, and that's a very important part that I, have a conversation with all the patients that come in, is that this is definitely a team effort. So usually, what my role would be to meet in consultation to figure out what the diagnosis would be, and then make correct treatment recommendations. But especially when it comes to something like IVF, it's very important because to have that team. We have a whole team separate of embryologists who will do, as you said, to do the procedures related to embryo culture, fertilization of the eggs. We have our nurse IVF coordinators are a very important part of the process because they're the ones who organize and do the calendaring and do the teaching of how to do injections and medications and so forth. So we have a whole group of people who help patients through the whole process, and a very, very important component of the whole fertility treatment.
It's a great team.
Yes, definitely.
Well, so we talked about what happens if the man isn't producing sperm, or we can't get them out the usual way. What happens if the woman isn't producing eggs?
So usually in a situation where someone's not producing eggs, it can be the most common situation is where they have very irregular cycles and a condition called polycystic ovary syndrome. That's probably one of the most common situations we find. And those are usually remedied by taking these medications that I mentioned earlier about Clomid or with the FSH medication. There can be situations also where there isn't any egg production because the ovarian reserve is so low that more or less the eggs are running out, and so the body's not capable of producing any more eggs. And in that situation, then the option we have is using donor eggs. And donor eggs are eggs from a younger woman, typically in their mid-20s, who would go through all the medications and the whole IVF process, and then we would use her eggs to fertilize, typically with your partner's sperm, and then grow the embryos and put the embryos back inside the patient.
So in that case, if you have donor sperm or donor egg, the baby is genetically related to one parent, but genetically related to the donor. Usually that's anonymous, but not always. Am I correct?
That's correct, yes. I would say the majority of people who use donor eggs, it's usually an anonymous donor. But we do have a few people who come in who want to use relatives. And sometimes they even have friends who are very willing to donate eggs. So we call those situations known donors as opposed to anonymous donors. So the known donors could be related, but they may not be. They could be friends who are willing to donate eggs.
Well, Alex, we talked about what if the man's not producing sperm, if the woman's not producing eggs. But what about a case where a woman doesn't have a uterus, or there's something about the uterus that makes it not able to carry a pregnancy?
Mm-hmm. Yeah, and that's the uterus is definitely a very important component of the evaluation. So we want to really evaluate to make sure that the uterus doesn't have anything inside, for example, fibroids or polyps that could interfere with the implantation of an embryo. We also want to detect if there's any congenital anomalies of the uterus, meaning abnormalities that you were born with in the shape of the uterus perhaps, or there can be septum, for example, that could interfere with fertility as well. So that's part of the common routine workup and testing that we do. If there are problems such as that, one approach, depending on what the issue might be, could be a surgical approach. So for example, if there's a polyp or a fibroid, we can go in and remove it. Some situations there may be conditions where someone might be born without a uterus, for example, in which case then we would have to use what we call a gestational carrier, or a gestational surrogate as it's sometimes called. So that would be someone where, a situation where we would use your own eggs, your partner's sperm, and put the embryo in someone else to carry the pregnancy. So the pregnancy would be genetically related to both partners, but it would be sort of like a host uterus in a way.
Is that risky business?
It's not risky because we definitely go through extensive background medical history of the potential gestational carrier to make sure that they are healthy. Most of the times they've actually had pregnancies themselves before they become carriers, so we know they've gone through pregnancy safely, and so as best as we can and do all the screening to make sure that it's as safe as possible.
We've been through lots of different options for treatments, from pretty simple, just take a pill to stimulate ovarian production of eggs, all the way to we need to find someone else to carry a baby for you. But lots of treatment options for couples with challenges of all types.
That's right, that's right. And another reason that a person might want to have a gestational carrier is if they have a medical problem that makes it unsafe for them to get pregnant. And so in those situations also would be another situation where they may want to use a gestational carrier.
Do you ever have people who decide just, I don't want to have infertility treatment, I think we're going to adopt?
Yes, that's right. And that is certainly another option. So after going through all the treatment options that we can do, certainly adoption is another avenue to start the family. So typically when I have patients, I usually say, the goal is to start a family. And there are many different ways to achieve that, one of which we can help with a lot, and that is using these medical treatments. But certainly adoption is another way of being able to start or add to a family.
Well, Alex, it's great chatting with you. I want to thank you for joining me tonight on Health Connections. Thank all of our viewers for watching today. Hopefully through conversation with Dr. Kim, everyone has learned that at the Palo Alto Medical Foundation we have many, many different ways to help with fertility troubles, to help people figure out if they need to see a fertility specialist or not. As a primary care doctor, our OBGYNs, our fertility specialists, all of us at the Palo Alto Medical Foundation believe very strongly that helping you achieve your goals for health, including the goals for building a family that's right for you, is very important to us, and we do everything we can to help you. And we have wonderful experts like Dr. Kim who use the most up-to-date technology for those of you who need help. Please always ask your primary care doctor or your OBGYN if you think you might need some assistance. And thank you for joining me tonight on Health Connections. KCAT Television, Los Gatos, Monte Sereno.